Okay, everyone, here's mini video number 2 in teaching in a DBT intensive, the topic of the DBT suicide crisis protocol. Where I left off in our last episode was I was going over all of these guidelines for dealing with suicidal crises. And now I'm going to move on, and in the PowerPoint slides that I have, the next one is called the DBT Suicide Crisis Protocol. So I want to give you the overview of the protocol, because then we're going to be going from there and breaking it down and looking at different parts of it. So here's how it flows, though. The overview is that it begins after you've been alerted to the idea that somebody might be in a suicidal crisis with increased suicidal risk, starting out by assessing the risk factors of suicide. And you do that by looking at their long-term risk factors, even if those are things you can't do much about now. And then you look at more of their imminent risk factors, either for suicide or self-harm. You move into, this is a quick overview, you move into validating their painful affect and connecting with them. You shift into focusing on the present situation, the last hour, the last few hours, what led up to this moment of crisis, as opposed to the bigger, longer-term picture. You try to problem solve a current problem that's contributing to this being kind of just too much to bear right now. And in doing so, we're going to be going over what are some high-risk environmental factors, in other words, factors in the individual's environment that increase the risk of suicide. And then high-risk behavioral factors, in other words, high-risk factors in the person's behavior that increase the risk of suicide. And these two categories are important because they're filled with possibilities of things that can be affected now, can be worked on. They're modifiable factors. Out of these, and coming up with a plan to problem solve, we try to get a commitment to the plan, and then try to troubleshoot the plan. In other words, start to imagine, why is this not going to work, or why is it going to break down as soon as we stop talking, or something like that. And because we want to anticipate a recurrence of the crisis response no matter how this conversation comes out, and reassess suicide risk at the end of this protocol. So these are the overall flow of the protocol, and we're going to break it down to different elements now. The next slide and the first topic within that protocol is going to be assessing long-term and imminent risk factors for suicide. So let's consider long-term factors. These things change over time. You can find them by looking them up on websites of suicide risk factors, of which there are several types, both nationally and internationally. So these days, what could I tell you about that? If you were to look them up now, and for the United States, you would have, what age populations are at highest risk generally? Well, a couple categories. One is going to be, for a while now, teenagers between ages about 14 and 25. Around that are a high-risk population. Another high-risk population is middle-aged men, and then definitely older men beyond middle-aged. And a population of age-wise that's increasing fairly dramatically in the last 10 years would be younger kids, ages 10 to 14. Okay. Now, if we go past age, what about just a comment about gender? Generally, you're going to have a higher suicide rate among males and with violent means. Firearms, jumping, hanging. And you're going to have, among females, you'll have a lower suicide completion rate, but a higher suicide attempt rate, as well as higher self-harm rates. And with women, when they successfully complete suicide, they're more likely to use poisoning or overdoses and so on. What about race and ethnicity? Well, typically it's going to be Caucasians in the United States in these age groups that are at higher risk. Lower than that is going to be, at the low end, is going to be African Americans and Hispanic populations. And quite high on the list is going to be Native Americans and Native Alaskans. What else can I tell you? Populations at high risk, and this would be partly covered in history, would be people of the following groups. The LGBTQ community is typically at higher risk of suicide. People with previous suicide attempts are at higher risk. People with self-harm, a pattern of self-harm behaviors are at higher risk. People with mental illness are at higher risk than non-mental illness. People with substance abuse are at higher risk. People from the military and veterans of the military are at higher risk. Okay? People who were traumatized as children seriously are at higher risk, and people with seriously neglected. People with suicides in their families are at higher risk, and people with severe loss in their history are at higher risk. What about biochemical or neurobiological factors? I don't have a lot to say about that right now. Research is ongoing, but for some time it's been known that people with a lowered, it's called 5-HIAA, it's a metabolite, a breakdown product of the serotonin process, so that is at lower than normal, and there is basically a functionally lower serotonergic neurobiological system. It seems to correlate with those who commit suicide. What else? There's also evidence of sort of a hyperactive hypothalamic pituitary adrenal axis, which is always part of the activation of the fight-flight system in us. There are other factors under research. The other risk factors we're going to talk about that are more immediate or imminent are going to be the environmental risk factors, the behavioral risk factors, and then a specific list of direct indicators of a higher risk of suicide now, a list of indirect indicators, and then finally is going to be a list of high-risk imminent factors, meaning within the next few hours or days. These are special ones that really indicate, better watch out for these. Okay, so let's go over first the environmental risk factors, which is the next slide. I'll tell you, the way I remember these is with an acronym, but it's totally unnecessary for you. And it's an acronym that helps me remember it is there's two S's and two M's. All right, first S is a factor called decreased social support. So somebody is more isolated. Their level of social support has gone down in recent months or more recently. They're more alone in the world. And so that's one risk factor. And another risk factor is the people who have what's called a minority status, which doesn't refer to ethnicity or race. This refers to whether you are in a situation where you are sort of one of a kind of who you are, as opposed to one of many. So that, let's say you are a higher up executive in a company, but you are the only female in that position. Statistically, you're at higher risk of suicide if there's a lot of other risk factors, right? If you are the only one of your race, if you are the only one of your gender, if you are the new kid in town, let's say somebody comes from somewhere else and they join school in high school or in middle school, and they are not connected to others. It's sort of this idea that in different social systems, somebody is not connected up, and they are a minority in that respect. They are alone in that respect, and they're more likely to commit suicide. And of course, if you have decreased social support, the implication is that a solution might be to try to generate increased social support, increased contact with people who care, people who matter to that person, who they've been drifting away from. Increased contact with the therapist or with a group of people if there's a group therapy. Another S, increased stress. There's been stress factors lately. There's been losses recently, or negative events, or disruptions or crises in one's life. So you're at higher risk, and the implication is that you might work on some recent stressor and try to reduce the stress of one stressor. And here's the interesting thing, is that even if there's a ton of stressors and there's a long history of trouble, I've found repeatedly that if I can zero in with the person on a recent stressor that has put them over the edge, that just working on that thing, even if it doesn't capture the larger reason the person would want to die, generates energy and focus and connection that can reduce risk. So I'll probably give some examples later, or just in a few minutes. The two M's I said. One is exposure to suicidal models. In other words, somebody is connected to people who have recently suicided or tried to commit suicide. Someone in the family has suicided historically or recently, or the extended family, or in the friendship network. Somebody is in a town, let's say a teenager's in a town where there have been a rash of teenage suicides or teenage suicide attempts. In a sense, this idea of suicidal models is that when somebody has recently suicided that you are aware of, and you yourself are already ambivalent about life, it sort of can, for some people, indicate that the door is open to suicide, and it can increase the thoughts about suicide and the risk of suicide. This could be if a poet that you like has suicided, an entertainer, an athlete, a performer of some kind has suicided that matters to you. Okay, so what do you do about that? You try to know about it. You learn about that. You hear what it means to the individual, and you try to counteract that, because people develop some really erroneous beliefs that if someone else did it, they should do it. If someone else did it, that means that it can be done now, and therefore I should do it now. Yeah, and other sort of erroneous beliefs that make one think that this is the time for me, the door is open. And the other M, big one, is the availability of methods. So means or methods for suicide, if you have them within your proximity, that increases the risk if you've got other risk factors, of course. If you have a firearm nearby and that's your intended method of choice, or if you have a rope to hang yourself, if you have hoses to hook up to the exhaust system of your car and put yourself in the garage or in the car in order to kill yourself that way. If you have hoarded a number of pills or accumulated a lot of pills that would be enough to kill yourself. All of these indicate that there's methods that are available, and therefore a huge intervention and an important intervention is what to do about those methods. So if I'm doing a suicide crisis protocol, I want to know what the methods are the person's thinking about. I want to know what the methods are that are available, and I want to get them further away from those methods. And of course, the methods that can be done quickly and irreversibly, I'm especially concerned about, such as firearms, where it's just there's no turning around right after you've done that. Even overdoses, which could be fatal, there's a chance, and it often happens, that somebody rethinks it after they've taken an overdose, and they call an emergency room, an ambulance, a 911, a family member or something, or they get help, and it's still not too late. But really, in any case, you want to get them away from methods. Okay? We'll come back in another video.